Now, I'm very pleased to be here to tell you about some new work that we've been doing on implementing psychosocial care into routine practice and particularly making it easy. Now, we've been working in this area for a while now, but this particular program is fairly new enough that we've only just developed our beautiful logo here, ADAPT, and new enough that we're still excited about it. And I'd just like to point out that ADAPT's got A for anxiety, D for depression, and P for pathway. And ADAPT, of course, is what people do to cope with anxiety and depression. And you'll see a little allusion to first aid there on the T, because we're trying to help people with this, so we think that's rather clever. But anyway. So there is a big literature now which tells us that, and it's not at all a surprise, that the prevalence of distress in people with cancer is high. And I'll just tell you about this one very recent and very high quality study that was done in Germany, where they really did do a representative sample from the population with a large number of over 4,000 people. And they not only got them to fill in questionnaires, but they also did a diagnostic interview with those people. So they're very certain that they've got this right. And what they found was that in any 4-week period, about a third of these people diagnosed with cancer had some sort of mental disorder, mostly anxiety, adjustment disorder, mood disorder, dealing with the stress of being diagnosed with cancer. So this is a very common issue. Now, we know that we can help people with this. There's lots of interventions that have been proven to be effective. This is a meta-analysis that was recently published in JCO, where they looked at 198 studies involving more than 22,000 people, and they found that overall, these interventions do have an effect, particularly if you pick people who are really distressed, and those effects are sustained over time. So we already do know how to help. We've got very good guidelines for how to deal with psychosocial care. In fact, and Australia has really led the way in this area. These guidelines, originally developed by the National Breast Cancer Centre and endorsed by NHMRC, are very widely distributed around our centres. And because of this high level of distress and the recognition of how important this is, there really has been a strong international call over the last 10 years for routine screening, so that we make sure that we find those people who need help and we offer them the appropriate help. And that's because we know that early detection and treatment does reduce patient suffering. It stops people from going on and getting worse. It improves their quality of life, and it reduces health service utilisation as well. So with all of that, how are we doing in practice? Well, my organisation, POCOG, recently reviewed what was going on in screening for distress in Australia as part of some work we were doing with Cancer Australia. And we looked at the literature, but we also interviewed some leaders in this field, both internationally and in Australia. And what we found was that screening is not conducted routinely in Australia. It happens on an ad hoc basis in individual institutions. It's vulnerable. It tends to start and then stop. And a lot of emotional symptoms are missed, or their severity is underestimated. And why don't we screen? Well, staff tell us that they lack confidence in knowing what to look for. They don't get enough training in this field. There's so many time pressures that this is yet another task that they have to fit in. And there's a lack of psychosocial staff to refer to and guidance in how to refer. And people are very conscious that they don't want to start screening if they can't provide appropriate care once they find people who need help. On the other hand, we also know that screening alone is not enough. Now, Canada, who's really led the way in pushing for screening for distress, has been successful, as you can see in this graph, over the last few years, since 2008, in increasing the rate of screening. But when they've looked at outcomes, psychosocial outcomes are not improved. So why is that? Well, US and UK data show that many oncology health professionals don't trust or value screening data and they don't respond to it. And so patient referral remains ad hoc, and you might get to see the psychiatrist if you talk to the bartender who refers you to the shoeshine boy. I think this is American. But you may not get there reliably otherwise. And synthesis of data from about 40 years now of screening in the general practice setting has shown that just screening doesn't improve outcomes. What you need is a clear clinical pathway and dedicated resources to responding to the screening process. So in response to that, POCOG, which is a psycho-oncology cooperative research group, has been developing an evidence-based clinical pathway for anxiety and depression. We've done that based on the evidence, but also very much by involving stakeholders in Australia to help us. And we did that to make sure that we had engagement from everybody who would be involved, to make sure that we were looking at everybody's perspectives, multidisciplinary perspectives, so that it would be acceptable to all groups. And we were hoping to produce a pathway that would be really practical and be able to be used. So we started by developing a draft pathway, and then we went to about 87 members of POCOG, multidisciplinary, and we put together 39 statements that would make up the pathway, and we asked them to indicate how much they agreed with each of those statements, and then give a free text response on why they gave that rating. And we looked at those areas where there was lots of agreement, and where there wasn't any agreement, we went back to them and to see if we could get a bit more agreement. So those 87 people who participated in that process came from a range of backgrounds, as you can see, and we made sure that we had people from rural and regional areas in Australia, as they have some unique challenges, as well as public and private and different sorts of settings. And what we found was that most people agreed that if you had a pathway, it would have to be tailored to the local resources, because everybody had different staffing and different patient mixes and different capacities. They all agreed that we should be screening, and that it should be formal screening with validated tools, and that somebody should be responsible. What they didn't agree with was how many steps there should be involved, what exact screening tools should be used, and who should be the person responsible. In terms of assessment and referral, there was broad agreement that you needed a health professional to talk to the patient face to face to find out what was actually going on and how serious this was, and that any recommendations you made for treatment would need to be done with the patient, who might have their own psychologist or psychiatrist or a different preference for help, and a need for patient education to destigmatise mental health. But there was no consensus on whether we should be screening and assessing all at the one time, and whether it should be by the same staff member or by a different staff member. There was broad agreement that we needed a stepped care approach, so that people with mild distress were offered a broad range of services, with more intensive services kept for people with greater distress. There was no consensus on whether practical and spiritual issues should be included in an anxiety and depression pathway or were unique and different, and whether we should be recommending timeframes. And in terms of monitoring and care coordination, there was agreement that we should be following up people, and that probably at lower levels of distress this should be done by the main treatment team, but at higher levels of distress you probably need specialised mental health professionals to take on that responsibility. But again, there was no consensus on who should be responsible for coordinating care. So in conclusion, that Delphi process told us that there was a broad support for a pathway like this, and that there should be routine formal screening, that we needed a stepped care model, and we needed to be flexible, but that we would need to be negotiating with each centre about who was going to take responsibility for this. So we've made a pathway which is flexible. It incorporates screening, referral and management recommendations, and it uses a stepped care model with 5 steps going from minimal to very severe with different recommendations for each. Now, you probably can't see this, but basically what the pathway says is that initially you need to work out whether someone is distressed or not, and if they are distressed, is it primarily anxiety and depression, or is it really pain? Because if it's pain, you probably need to deal with the pain first and then come back and re-screen. If it is anxiety and depression, you need to work out whether there's something urgent that needs to happen, and if not, then triage into the different steps. Once you've triaged into the different steps, then we've got individual a different pathway for each step, which recommends who should be providing care, what sort of care might be appropriate, and what sort of follow-up should be appropriate. So we've got this clinical pathway. Can we get it into routine practice? Now, we're not bad in this country and probably internationally at doing descriptive research. We've got better at doing randomised controlled trials to get evidence for efficacy of intervention, but we are very bad at knowing how to get things into clinical care. And in fact, if you look at the literature, less than 6% of studies actually try and help you work out how to get things into routine care. So there are some frameworks out there that help you. This is one of them, and the PERI model suggests that you really need to get the context right. You need to get, we talked about leadership this morning. We need to get the leaders behind it. You need a culture which encourages change. You need to have the resources that's going to make this possible. You need to have good evidence so that people believe in what you're trying to do, and you need to have processes and structures that will overcome barriers and facilitate the introduction into care, and that's what we're trying to do in this program. So we started off by going and talking to people within the oncology services about what would stop them adopting this pathway and what would help. So we interviewed 12 people in detail and had a look at that. And what we learned from them was that there was a lack of time, there was a lack of staff, sometimes there was even a lack of a room to go and sit in and talk to someone about an issue. And there was no agreement on a screening tool or cut-off scores. And again, as we had come up in the Delphi process, there was a confusion about who's responsible for screening, who's responsible for assessing, and the ethical responsibility of having someone to refer to. Fortunately, these 12 people were also constructive and came up with good ideas to help us, and they said, you've got to engage. So engagement with psychosocial services and the nursing staff as a starting point is really important because they're the ones that are actually going to do the work. And you've got to offer training, and oncologists and nursing staff need to understand what psychoeducation is and have some simple resources that they can give to patients. They said, convince us that this is important. So you need widespread education that highlights the importance of psychosocial assessment as well as the efficacy of interventions, and you need to tell us how it's going to reduce our time, not add time. Tell us how this is going to help us as well as help the patient. So how is this going to improve the clinical life for the coalface oncologist as well as improve the life for patients? And you know, I have every sympathy for these busy clinicians. They really want something that's going to not be a burden. Now, they also talked about patient barriers in terms of the stigma of mental health, and we've just had Mental Health Week in Australia, and we've had lots of media attention on mental health, but we also still know that people feel embarrassed to talk about their struggles with mental health. There's still a stigma associated with mental health, and many referrals don't get taken up because of that. People feel embarrassed, they don't want to burden the cancer care team, and they feel that they're not bad enough to warrant care, that other people must need this help more. So one of our participants said, for a lot of people, it'll be the first time they've ever spoken to someone about distress, so it's not a simple step. And, you know, there's great resistance with some people. There's one gentleman who's just refusing point blank to see anybody, yet his wife is telling me that he's spending most of his time in tears at home. Wives are great allies in this, you know. So referral and how to make referral is an issue. Otherwise, you know, we can offer psychiatric help, but, you know, it won't be taken up. So in terms of enabling, our participants said we need patient resources, we need booklets to give to people, we need you know, internet sites that normalise all this and help us make these referrals, and we need staff training on how to make an effective referral so that people feel comfortable taking it up if they would like it. There were also system barriers and solutions discussed. So the culture was emphasised as being critical. There needs to be explicit support from the institution that spending time on these issues is time well spent, that it's valued and supported, that people are given time to do it, and that it's a priority so that everybody's engaged in this being an important service initiative, otherwise it won't happen. And it needs to be a system level where these things are integrated into routine documentation in IT systems and in quality to review so that it's just part of care. They felt that if we could get support from health policy at state and local level, that would help. So if something like this was built into the Memorandum of Understanding, it means that the local district level, you've got senior buy-in. So that was, we had a lot of barriers and a lot of facilitators, but this next program grant, which the Cancer Institute New South Wales has funded as part of its translational program grant, is aiming to really look those barriers in the eye and see if we can get over them. So we're aiming to facilitate the integration of the clinical pathway into routine care, and also to learn a bit in the process about how to implement guidelines and pathways of care, which might be generalisable to other issues. So we've got a great team of a multidisciplinary team plus a consumer advisory group led by John Stubbs, and that covers a whole gamut of people. In red there is Tom Hack, who's our international expert in psychosocial implementation from Canada, which has had a lot of experience in this. And I should also acknowledge our new program director for this, Heather Shepherd, who's doing a fantastic job in getting this underway. We've formed partnerships with 4 of the translational cancer research centres who we really hope are going to be instrumental in supporting us at the higher level and encouraging buy-in and engagement. And we've thought carefully about how we're going to address each of these barriers. So in terms of the administration, a barrier being lack of support, we're hoping to get some real clinical and administrative champions on our side. We haven't quite started the process of approaching sites. We may be knocking on your door shortly, looking for champions to champion this work. We're hoping that involving the TCRCs and the Cancer Institute New South Wales as well will give us that leverage. In terms of general oncology staff not feeling that they own this, we're involving key staff from all disciplines in tailoring the pathway to the individual context. So the first step is really going into each site and working out how it's going to work in that setting. In terms of lack of education about how to talk about this sort of thing and how to make a referral, we're developing a set of educational resources with role-play demonstrations and cases on how to talk about these issues, how to screen and how to make a referral. And this will be available on EviQ, which is the online oncology education portal which the Cancer Institute runs. And we're basing that on some materials that have already been developed in Canada, but adapting them for Australia, because Australia has some unique features. In terms of time, and time is critical in our health system, we're developing an automated system a little bit similar to what was discussed this morning. It's going to be an online portal which will queue patients to complete assessments at baseline and at follow-up. It'll provide a graph of scores over time so the patient can see how they're tracking as well as hospital staff. It'll send an email to staff when a patient or when somebody gets over a cut-off which suggests that they might be struggling with anxiety or depression. There'll be an automatic email sent to the person that site has designated responsible, which basically says you need to talk to this person and work out what's going on. It'll provide a link to a referral template so that if once there is that sort of discussion, it's felt that they could benefit and they agree that they would like to see a psychologist, there's a referral letter a click away. And it's going to be linked to electronic records such as Mosaic if we can, but there's lots of challenges around that. What about the psychosocial staff? They freak out that they're going to be drowned in referrals if we start this process. So to address that barrier, we're developing an online cognitive behaviour therapy intervention specifically tailored for cancer patients. And there's good evidence in the general population that these sorts of online interventions can be very effective in treating anxiety and depression. So we're tailoring it to the cancer context. We're basing that on This Way Up. I don't know whether you've seen that. It's an online intervention that came out of the University of New South Wales, led by Gavin Andrews. It's had about 25 randomised controlled trials showing that it is effective in reducing anxiety and depression. So we're working with that team to tailor it to the cancer context. So we're hoping that lots of people may be able to benefit from that. And so the psychosocial team will really only have to see the most serious cases. And in terms of people's reluctance to burden staff and the stigma associated, we're hoping that this automatic process, which is part of routine care, will make it more normal for people to participate in the process. And we're also developing some written and online resources to really explain why this is important, why mental health is as important as physical health, and the fact that this is a normal part of care. So we're hoping that if we address those barriers, if we garner all these facilitators, that we're going to be able to actually implement this. We were talking this morning about the fact that this is never easy. We're going to evaluate whether we're successful in the clustered randomised controlled trial, which is evaluating how much effort do we need to put in. If we provide all these resources to sites, how much time and cost should we be spending in implementing and supporting this? So the clustered randomised controlled trial is really is randomised to a fairly basic implementation strategy or a very intensive implementation strategy. So all sites will get access to these resources that we've developed and to the pathway, and have an on-site briefing session and posters advertising the program. But the intensive arm, we're going to have training and ongoing support of these local champions. We're going to provide audit and feedback to each of the sites at the beginning and halfway through so they can see how they're going and where they're having trouble. We're going to have face-to-face education regarding the portal, and we're going to facilitate the tailoring of the pathway to the local setting. We're going to provide IT support, a very critical component of all of this, and other strategies to address the specific barriers and facilitators at each site. And we're going to cost both approaches. And hopefully by the end of the study, we'll know, can we get away with good resources and good basic facilities, or do we really need this more intensive implementation strategy? So the outcome, we hope the clinical pathway will remain in use. We hope we'll learn a little about implementation, and ultimately, of course, we hope there'll be better outcomes for our patients. So in summary, I think if we're really to improve psychosocial outcomes, we need proven interventions. We need to identify people, but we also need to pay a lot of attention to how we implement this. And I think that although it's not easy, I believe it can be done. There are examples in America and Canada that are starting to come through. And the alternative, I think, as for these dogs, I had my own blog for a while, but then I decided to go back to just pointless, incessant barking. Well, I don't want to be one of those dogs, you see. So, thank you. Now, I believe I've done that with lots of time for questions.
My
Julie.
learned friend has come in what I call, in public service terms, 30 minutes before the minister. Are you with me, people? So we are going to engage at depth with psychosexual well-being, psychosocial well-being, and we're going to not only have a lot of questions and answers, we're going to share examples of great work that's being done here in New South Wales. I'll even get our American friends in if required. Are you with me, people? Because Gillian Skinner wants to meet each and every one of you. Now, who would like to begin with a question? First of all, a big round of applause, please, for Phyllis. Thank you, and I'll just hurtle towards you and ask you to say your name and where you're from. Do you mind standing so they can stare at you? Oh, yeah.
Okay. Hello, my name is Sharon Pritchard. I have suffered from cancer myself, and I've cared for a number of people who have suffered from cancer, and I lost a friend recently, just last week, to cancer. So I sort of am coming at it from the patient experience perspective. I'm interested in the notion of patients and why they don't seek help or can't seek help or don't or won't accept help for anxiety and depression. And I was wondering about your thoughts on the language that surrounds cancer and cancer sufferers, mainly in the media, I suppose, but it's almost everywhere, on cards, in general conversation, and it's called battling, surviving, being brave. And I wonder how many people hear those words constantly in relation to cancer, and when they don't feel brave are not game to come out of their homes or their beds or somewhere else. And what do we do about it?
I think that's a really great point. And which of the US presidents was responsible for the war against cancer? Yes, Nixon. And I think that terminology around the war against cancer has bred a whole lot of those terms about fighting. And also some of the early research which said that a fighting spirit would increase survival has also been responsible for a lot of this issue, where people feel that they can't admit to not coping because they might actually be worsening their chances. So whereas we actually know that being able to talk about feeling bad makes it easier to feel good. But that permission to express emotion is often lacking in for the general public and within cancer services as well. So I think that's a really important point.
Good, thank you very much.
Phyllis, congratulations on a very clear talk, but also a very ambitious study. I had two comments or questions.
Did you just say who you are?
Who I am? I'm Jeff Delaney. I'm Director of Cancer Services for South Western Sydney. Sorry, I feel like you're pushing.
I know. What I'll do is I'll hold you from behind. It's about volume.
Thank you.
It's better than a cannula.
So the first point is, as you're aware, our detection of psychosocial issues in non-English speaking patient is even more abysmal than it is in English speaking. So I'd be interested to hear what your specific plan is around non-English speaking patients. And my second comment is, and I've struggled with this myself, a lot of the cancer patients hit the cancer centre quite late in their journey because they're having surgery, or they don't hit the cancer centre at all because they only require surgery. So I'd be interested how you're planning to integrate that into your research.
They're two excellent questions. So when we were writing our grant, we debated about non-English speakers because we've done work ourselves showing that anxiety and depression is more of a problem in our non-English speaking immigrant population, partly because they have those communication challenges and partly because they don't understand our health system, and often because the support they have is back home, overseas, so they're often more isolated. So they're a really important group. We decided that we'd made our job hard enough and we would start by doing it in English speakers with the hope that we would be able to generalise out. But I do think that's a really critical point. And I think in some communities, it's even less permissible to talk about emotion. Certainly in our Chinese community, we sometimes find that they'll talk about their pains and bodily sorts of symptoms. They're much more comfortable talking about that when they're really talking about anxiety and depression. So I think we need to be clever about picking up those sorts of cues and opening those conversations. But it's certainly a really important area. In terms of tackling how we pick this up outside of the oncology centres, and there is a group of patients who will only ever see a surgeon in their private rooms and never get to the oncology centre. We're not tackling that in this particular project, but again, I think it's a critical area for thinking how we can link up with the general community, and I'd be really interested in other people's views on how we can go about that as well.
Does anyone want to offer a comment on that? The linkages to patients who are seeing private surgeons privately and may not link into support systems. That's the issue, isn't it? Does anyone wish to comment on that? Yes, thank you. I'll just come over.
Of course, the GP is a linchpin.
I'll hold it. Do you mind? I'll hold it.
Thanks. Tony Prater. I'm Director of Cancer Services for Hunter, New England, and for my sins, a gynecological oncologist, therefore a surgeon, I think. And I just wanted to make a couple of comments on that. Yeah, I agree how difficult it is to engage surgical, except that at least in the public system, we do have a point of contact where something like this could work that we've never actually used, and that's the pre-operative clinic, because all of the patients who are booked for major oncological surgery will actually go through that clinic, and we've never really considered making that a starting point.
That's great. I'll be knocking on your door. You can be one of our sites. But that's a great suggestion.
I think it's much more difficult in the private sector, simply because the resources are not there, and if the patient only requires surgery, and a very substantial proportion of patients do only require surgery, there is no real point of contact with those sorts of services within the private setting, except for specialised services like some of the breast cancer services, where they may be situated in a private setting, but they have their breast cancer nurses and their psychologists and social workers, etc.
That's right.
Thank you.
There was someone else. Thank you.
And breast cancer certainly has had some advantages in this area.
Okay, you may hold it, Julie. I'll try not to rip it out your hands. This lets me put my Cancer Council hat on. There's been some studies that have been done through the Victorian Cancer Council around prescriptions for referral to the 131120 number, which does put these patients in access to a cancer nurse, albeit not one who's navigating them through the system. So I think that is one option, and that was very successful. It was in terms of outreach phone calls, so the patients were recruited it was a colorectal cancer study, and the patients were recruited and gave permission for an outreach phone call from those nurses to begin to provide frontline support. If you actually put that in play with this kind of system that operates in Queensland, and I'm big on the equity issue, and so in Queensland what the Cancer Council up there does is they have a psycho-oncology service that's operated entirely by telehealth, and it provides service to people right across Queensland. So if there is no access within your service, that service can be accessed. That telehealth service is now being commissioned by Cancer Council Victoria to provide that service in Victoria. So we actually have to get with modern technology and recognise that many patients actually want to provide this sort of support to themselves. So, and I know Phyllis will have talked about her beyond the modelling off Beyond Blue and what can be done in depression. But at the same time, I think, and Tom talked a little bit about yesterday about the cockroach, which I call the capture no release approach to the cancer system, and that is that we have to stop thinking that all this service has to be provided within the acute care setting. It's actually not where patients want to get it.
Thank you. There was someone else here, wasn't there? Yes, thanks. Do you want to stand up?
Melissa Cumming, I'm Director of Cancer Services and Innovation. I'm based in Broken Hill, and you'll note that I'm in the far west region sitting now. I've moved.
Hi.
Just a comment, really. I'm just a comment and a cautionary tale around the balance between that face-to-face service and using video conferencing, which we do because we have to do it where we are because our patients are geographically isolated. But we have a huge age population. Most of our patients don't have access to the internet, let alone mobile phone coverage in some of our remote sites. We have a lot of Indigenous people, low socioeconomic people. So I think not the reliance on, but the use of online courses and those sorts of things shouldn't be a replacement, just a supplement to face-to-face services or phone services.
And I think that is an example where tailoring to different sites is going to be needed. So some sites will have a population where there's pretty good coverage of computers, and the data in Australia is that we're hitting, well, I think we've got 2 mobile phones per person in Australia, which means that some people must have 4. And we're getting very good internet and computer usage as well, but it's patchy, and in some areas it's going to be lacking. So we're going to be able to solve some of the problems through internet-based therapy and perhaps telephone lines, and in other areas we're going to have to find some other solutions. So one size is never going to fit all.
And how are you going to choose your sites?
Oh, we'll choose people that want to play with us. We're still working on choosing sites. We are thinking of including sites that have a reasonable throughput, but we're also going to stratify to make sure that we include some rural and regional areas so that we know we can test how this will work in different areas, because it's going to be important that whatever we produce is going to be useful across Australia. So we're still in that phase of deciding on the sites.
Okay. Questions or comments, ladies and gentlemen? Or anyone who feels they are doing this well where you are and you'd like to share your systems? Thank you. Yeah, please.
Just in response to Melissa, I think one of the things though is that if you utilise these sorts of internet resources and telephone resources and telehealth for the people who can do it, it frees up resource to actually improve the equity for the really hard to reach groups. Whereas I fear at the moment that most of our resources going into articulate, well-educated women with breast cancer. And if we could just tip that a bit, I think we'd free up a whole lot of resource.
And I think that's also where the routine screening of everybody is important, so that everybody gets a chance to be picked up, not just the people who have the courage and the articulateness and the understanding of the health system to speak up. So it is an equity issue as well.
Questions or comments, ladies and gentlemen? Thank you.
Hello, I'm Tracy Spinks from MD Anderson. I just wanted to ask, I think this is a great idea. So if it proves successful, would you give some consideration to expanding this to also help caregivers? Because we know caregivers have a lot of burden, psychosocial distress as well, and that sometimes can impact the health of the patient.
I think the caregivers are critical. The evidence is that there's sometimes more distress in caregivers than in patients themselves. Again, we put this into the 2-heart basket for this particular project, but I think it's really critical that we can expand. I think that health services in general are finding it difficult to address the needs of caregivers because they're already so overburdened trying to address the needs of patients. So resource issues would be really critical once we start expanding out to caregivers. But for example, the This Way Up online intervention can easily incorporate a referral to the general population, and could easily be expanded to have a version that's suitable for caregivers, and that might provide a solution to the resource issue. But I agree that caregivers are often very vulnerable in this context.
I wonder if I might ask Dr. Feely to just give us some insight into how they approach this where he's working, and then I'll come back to other questions or comments. Thank you.
Okay. No, thank you, and thank you for a wonderful presentation. So MD Anderson formed a Department of Psychiatry about 20 years ago, hired an academic department chair, and began dealing with the occasional referral, and they were occasional referrals. And one of our physicians in chiefs said, wait a second, we have to have a better approach. And so he formed a group called the Psychosocial Council. And the Psychosocial Council met many, many times to try to come up with a plan for how to identify for the Department of Psychiatry those patients who were at risk or demonstrating a need. Tracy had to remind me of the name of the tool, and there's a good reason I forgot about it because it was weird, but it's called a distress thermometer. And the patients are administered this by the nursing service on every visit. And the distress thermometer takes the temperature, if you will, of our patients in terms of their emotional needs. And when a certain score is reached, and if anyone's interested, we can find out the details because I don't know the fine details, but it triggers a consult to the psychiatry department and also alerts the nursing service to the need for that. Let me just make two other comments. This is profoundly important. I've been in critical care medicine for 40 years, and one of the clinical observations I made that I couldn't prove, like many of the hypotheses I couldn't prove, was that the emotional well-being of a patient before they entered a critical illness, and I consider cancer a critical illness, really determined the outcome. And we would have patients come into the ICU before I was even involved in cancer, and they or their family would say, he's not going to make it, I'm just not going to make it. And darn it if that didn't happen. And so there is a mind-body relationship that is really profound, and we need to capture that and link it. And the other comment that I'll make is one of the incredible contributions that our first chairman of psychiatry made, and his name is Walter Bale, is that he changed the approach to, he dealt with for many years with our patients, but also realized, to Tracy's point, that it was our caregivers that needed a lot of help. And the area that he developed was an area of teaching clinicians how to talk to patients and how to break bad news and how to reach out to patients. And so what you're doing is tremendous, and you're to be congratulated. So, and thank you, Julie, for having the opportunity to.
Just before you go, I guess I just wanted to ask that, earlier today in your opening presentation, you talked about outcome measures that went beyond the immediate time in hospital, longer term, that were patient focused. And I think it was also you who mentioned the need for the opportunity for patients to be able to give feedback anonymously. And I'm just wondering if those sorts of capacities for the patient to give longer term feedback and anonymous feedback might enable us to gain the evidence, to get the resources so that people have someone to refer to. Because again, this is a bit anecdotal, but certainly in my own experience and talking to others who've had cancer, you are so desperately grateful to the people who are treating you. And you witness firsthand just how pressed they are for time, that it almost feels disloyal to raise something like the fact that you're weeping in the car park. Do you know what I mean? Mm-hmm. And so I think that opportunity for longer term feedback and anonymous feedback might provide the evidence of distress.
Well, but I do think that we need to change our clinicians' attitude towards patient-reported outcomes. And I'll give you a good example of what Tracy and her team, I'm glad you didn't have to push my back into it, have encountered. And a lot of these patient-reported outcome tools that are validated tools bring into play the patient's emotional state. And a lot of our clinicians have said, well, wait a second, if you mandate that every one of these patients tells us that, gee, they may be feeling a little more depressed and maybe I'm feeling a little bit suicidal, let's be sure that somebody reads that and uses it and uses that information, because the fear is we give these tools to patients and then nobody looks at it. So I think there's a tremendous power in all of this, but I think we have to transform the thinking of clinicians to think that patient-reported outcome tools are really effective and important and are like laboratory tests of things that the patient wouldn't necessarily tell the doctor, just for the same reasons that you're talking about.
It's as good as a rat.
And I think the distress thermometer, weird as it is the recommended tool for at the beginning of the process of the clinical pathway that we're implementing, although we are giving sites some latitude in using their own if they have it. It's probably the most widely accepted and used tool. It's a one-item measure that people can indicate their level of distress. It does need somebody to talk to the patient and find out what's going on afterwards, but it's a really good sort of screening tool. And I think the other thing about just that comment that you've just made, it just reinforces how important it is to have a clinical pathway and steps in place when you introduce screening rather than just introducing screening.
Any other question or comment? Thank you.
Oh.
Hi, my name is Danielle. I'm one of the cancer care coordinators from Liverpool Hospital. We've recently implemented a generic care coordination model, switching over from a tumour-specific one. And as care coordinators, part of our assessment is to actually do the DT on all patients that we see and to refer onwards based on the findings of that DT.
And what's a DT?
The distress thermometer, sorry, that's the tool that they were just talking about. And we are very well placed to do that because we do see patients at the beginning of their journey, and it is part of our role to refer onwards to other allied health. But we also do a lot of the psychosocial care ourselves. I know myself, I get a lot of phone calls from patients visibly distressed. They don't necessarily want a referral onwards, they just want someone to talk to, and they want that person to listen to them and hear what they've got to say. So we do a lot of that ourselves without any actual formal training in counselling or anything like that. You do it as a nurse. So I think a pathway like this will be so invaluable so that we know that we're actually doing the right thing for our patients as well.
And certainly in the pathway, you know, at the initial levels of minimal to mild distress, which really covers everybody, because who isn't at least mildly distressed when they get cancer? You know, the standard of care is that sort of empathic communication with the treatment team, and that's documented in the pathway. So you're already part of the pathway. Well done.
Any other question or comment, ladies and gentlemen? Thank you.
And there was a...
This is my obesity reduction work.
Hello, I'm Lindy Lawler. I'm a continence advisor from Central Coast Local Health District. I run a local prostate cancer support group and also see men preoperatively before their radical prostatectomy. And for the men undergoing the surgery, the main cause of their stress and anxiety and depression is their incontinence, and also more so their erectile dysfunction. And unfortunately, we have nowhere to refer them to. So if we had a dedicated sexual health counsellor or even a men's clinic to refer them to, I think would alleviate a lot of their anxiety and depression.
And, you know, I think I mentioned before that at the very beginning of the pathway, we do try and work out whether the problem is really primarily anxiety and depression or primarily symptom related. If it's symptom related, we really need to deal with the symptom first. I haven't got the answer to your referral problem, but I agree that that's really critical, and if you can help people to address those symptoms, that's often all that they need.
Was there someone here?
Yes,
Thank
there's
you.
someone over there who's been trying desperately.
My name is Dr. Ankit Jain. I am one of the medical oncologists from Coffs Harbour. Probably this is a question in general to all the group. Like we discussed so many tools today for implementation in clinical practice and for the research. The biggest problem I face sometimes, like when the administrative staff and the nursing staff, they are dealing with this tool-based projects, and when they are giving that all the tools to the patients when they are waiting in the clinic waiting rooms, it's a lot of work for the nursing staff and the admin staff, and there is always like when I speak to my clinical trial nurses, like there is always an issue with the investigator-initiated trial and pharma-driven trials in terms of funding issues. So if you have, like if there are a lot of ideas also in terms of tool implementation and all, it's hard to give that many tools to the patient and who will deliver that tool and get that information. So I really want a some comments that how to balance that thing in like bigger centers, how you are managing that problem. Because my nursing staff came that it's enough, it will be difficult to go beyond this. And as a principal investigator, then I may need to stop that study in between because they are not in a situation to deliver that many tools to the patient. So I think...
Okay. Thank you. A comment, Phyllis. Thank you.
Yes. So, I mean, I guess you're talking about in general the problem of the burden on staff of participation in studies and having to get consent. One of the nice aspects of the study that we're doing here is that we're really studying systems. So we're inviting people to participate in screening as part of routine care. So individual consent from patients is not required in this study because in the end we're not going to be asking, we're not trying to prove that what we're doing is reducing anxiety and depression because we believe that the evidence is already in that we can. What we're trying to prove is that we can change systems and staff. And so the primary outcome of this study is the degree to which the pathway is followed. So we will be looking through the portal at the degree to which the pathway is followed as opposed to individual patient outcomes.
Ladies and gentlemen, I feel we've reached a point where we're going to end this session. And I want you to thank Professor Phyllis Butow not only for an incredibly compassionate and systematic presentation, but doesn't she strike you as the sort of person you could sit down with and tell her the truth about how you're feeling?